take it easy. We want the stem cells to actually have a chance to work without you putting too much stress on them. And then we do a follow-up. We've moved our second post up to 12 weeks, and we found that's a better follow-up, and then that's when we re-image and we check everything out. Okay? Yes, ma'am.
Dr. Bone, first I would like to tell you, if I had a smoke, it would be bad to the bone.
Bad to the bone.
I'm a former patient.
Oh no, his head's gonna be
So bad. You would think he's getting married. All dressed up, right? Or hot date one.
I don't care what it costs.
I love it. I love it.
I want to know how long does, okay, you said you get the one injection. How long have you seen before you have to have another one? How long does it last? That's mine.
Yeah. So it all depends on how much regeneration occurs. Okay, so like the knees that we just looked at. Okay, so let me backtrack just a second. So, like for instance, this patient, pretty much bone on bone, we did both knees, we re-x-rayed at 9 weeks. Now, when you look at this x-ray, that's not normal cartilage. Okay, they're not back to normal yet. That's not, well, about half of what normal cartilage should be in this particular body type, okay, at 9 weeks. So, all of that depends on, after the stem cells have had the entire amount of time to work, how much regeneration occurred. If it goes all the way back to normal, and I want to think that this patient was 70-ish, so then we got to figure we've got 70 years. Okay? If it stays at half, then I figure you got 35. Okay, does that make sense? So it all depends on how well your body's able to take the stem cells and regenerate, and how much regeneration occurs. So, one of the things that we do in our policy, again setting the gold standard, is that if when we do our follow-up at 12 weeks, we're not satisfied with the amount of improvement that you have clinically, then we're going to do another injection for you. No cost. Okay? Now, sometimes we factor that in when we look at the severity of a case, and if we say, well, you're going to need 4 milliliters of stem cells instead of 2, and we're going to split it up in 2 applications, the cost might be a little more. But if we misestimate or it doesn't turn out right, we're going to absorb the cost and we're going to do it for you again. Okay? Nobody's doing that. Nobody in the country that I know is doing that except us. But I want to ensure that if a person comes to my office and they pay us that kind of money, that I want them to get the result they're looking for. Can I guarantee it 100%? No, I can't. But everybody that we've had that's done stem cell treatment in our office so far has done extremely well. We had one gentleman that did bilateral knees that wasn't where we wanted to do, and we gave him another stem cell injection at 12 weeks. He was better, but not quite where we thought he should be yet. Okay.
So I heard you talk a lot about it, but I didn't really hear you talk a lot about like above the ears.
Yes. So this can be applied to spine too, and it's just, you don't see a lot on x-ray with spine because the disc is 80% water. And so if you've got a degenerative disc, stem cell treatment's not going to make the disc get high again because it's 80% water. But it'll heal all the surrounding tissues, the nerve tissue, and it works extremely well.
Way I have pain, I'm telling you, it's bad.
So it will help with
Yes, correct. It will help with a ruptured disc. It will help with degenerative disc disease. But you're not going to see somebody be, like when you look in the spine, the disc, different from the knee, there's different material. So in the spine, it's not cartilage, it's a disc material, and the disc is 80% water. So when you see degenerative disc disease, it's different than wear and tear in like a knee or a hip. It's actually, most of that is the body is dehydrated. Do you know that 97% of the population is dehydrated? But I can actually get a disc back when it's degenerated. If I can rehydrate, I can do decompression and do stem cell. I can get a disc back.
Okay.
Yes, ma'am.
My question may be a little silly, but I'm not a doctor, but I'm gonna ask it anyway. Does a cell contain blood in it? And if it does, can a person get a virus from the stem cell?
If the stem cell, so part of the safety, and when we harvest the stem cells, is that we test all the cells to make sure they're clean of any viruses or bacteria. Actually, we don't want any RBCs, red blood cells, in any of the cells because red blood cells actually will inhibit the growth factors and the cytokines from producing. So they actually have an inhibitory effect. That's why when we do our PRP injection, our accelerated GF, we do it first because we don't want to reintroduce the possibility that we didn't spin it down good enough and there's still some RBCs that are not detectable. We don't want them going in the joint. It's a good question. Yes.
I've asked 85 doctors and 86 of them told me they've never heard of it.
Lumbar radiculopathy? It's very common.
And that's what I'm on a crutch for today. I mean, every now and again, I literally woke up out of my sleep last night, 1 o'clock in the morning, leg just dropped.
Does your foot drop? You can't lift your foot?
I couldn't move my entire leg. It's like partial paralysis, basically, is what happened. But the pain is so intense.
So I'm not a female, but most females will tell me that have had childbirth that and a kidney stone are more painful than childbirth.
It is really bad. The first time this happened, it terrified me because both legs stopped working. I mean, they were like, they literally stopped working.
How old are you?
I'm 31. Same pain, same intensity in both legs. And it starts in the knees and it runs up the hip and it centers like in between my shoulder blades. For some reason, that's what the pain was localized. But my leg was completely numb. Like, just say for instance, your leg goes to sleep, it starts to wake up, it's got that real tingly feeling where you don't want to move it. That's the experience.
So you can have a wide range of symptoms with lumbar radiculopathy. Understand that different nerves carry different sensations. Most people don't realize that you have one set of nerves that carry pain and then temperature, whether it's hot and cold. You have another set of nerves that actually carry sensation, where you're numbness and tingling. You have another set of nerves that are motor nerves that control your ability to move. So you can, depending on where your injury is and how the nerves are affected, you can have one or all of those symptoms. But at the end of the day, the symptoms, regardless of the type of symptom you have, is not what's important. What's important is having an accurate diagnosis of where the problem is and then having the treatment to actually resolve and regenerate whatever damage is to the nerves. Okay? So when a person that's dealing with something like you're dealing with, it's very critical that with nerve tissue that we try to get to it earlier rather than later, because even though the stem cells are miraculous and they do great things, some nerve tissue will not regenerate if the nerve completely dies or it's been there long enough, which is why we haven't been able to completely take somebody who is a paraplegic or quadriplegic and get them back. Now we've seen some improvement, but not complete regenerative effects. So the longer you allow a condition to exist when it deals with neural tissue, well really any, the less chance you're going to have of getting better regardless of what you do.
I diagnosed with myself. So I looked up the symptoms of it.
You diagnose yourself with looking up the symptoms?
I finally
Please don't do that.
I
Google can be a dangerous thing.
True. But it was accurate this time. Comprehensive pain specialists, they like hit electrodes all up and down my body. Took needles and stabbed me in my back.
Electromyography, yes.
My back.
It's no fun.
Turned out it was 2 different places, 2 different vertebrae in my spine that broke. And they told me there's really nothing I can do to prevent it from flaring up. And my ears stopped hurting. But they don't even take half of it. Once it sets in, it's there for 4 or 5 days.
Well, fortunately for you, if I had a nickel for every time somebody came into my office and told me that they were told they couldn't be helped, I could have retired a long time ago. And most of those people we've been able to help. Yes. Any questions? Any questions? Okay. Let's start back here then. Yes, ma'am.
Okay. If you inject your knee, would you recommend having physical therapy first?
Well, it depends on what your wants and desires are. Now, it's not necessary to have physical therapy before we do the injection. I do have people that have come in and they've never had, they have osteoarthritis of the knee. They've been told they need a knee replacement. We X-ray them and their osteoarthritis is mild at best. So a knee replacement really was not on the table. They've not tried physical therapy. They've not tried visco supplementation. They've not tried anything that's conservative to try to help with their problem. Well, in that situation, I want to give a patient all their options and say, well, these are things that you could do that are covered by your insurance that you haven't done. That's the minority. Most of the people that show up have done all of those things, and like they worked for a time and didn't work anymore. But no, there is no physical therapy or rehabilitation that is recommended before or after this treatment.
I've been told that I'm not a very good candidate for knee replacement.
You've been told you're not a good candidate?
Not a good candidate because of my other health issues, like the diabetic, heart issues. Does this procedure here work better on patients like me that don't have to go through the anesthesia and everything?
Well, the great news is it gives you an option, and it works very well for patients that. And this is the exact. You're the ideal candidate that excites me the most, because the people that come in. I mean, listen, I don't think surgery is a great option, but at least if you can have it, it's a option. Okay, but I don't think it's a great option. I don't think it's the best option.
2 weeks ago, I begged for knee surgery. That's how bad I was hurt.
So
and I mean, he asked me and told me, he said, I won't do it.
You won't do it.
Because he was too high a risk on everything else.
So those are
That's
the.
when we started looking, you know, you got to do something.
Yeah, you can't. You don't have any other options, and so those are the patients. We've had several patients just like you come in, and they need a knee replacement. But I mean, as far as looking at that option, they could have a knee replacement, but they don't qualify medically, so they're out of options. And they've done the corticosteroid injections, and they've done the visco supplementation, and they've done the physical therapy, and they've done the opioids, and they are doing them, and they don't have any other options. So it's very exciting for me to take somebody like you that has no hope, and now give them hope, and not only give them hope, but have a better outcome than they would have had if they had the knee replacement. Good question.
I got charcoal.
Familiar with that? I have not worked on anybody with that, although I have a patient right now that's scheduled to come in with that was at our lecture, I guess it was last week. So had that condition, and so stem cells can be applied. We're not afraid to apply stem cell in any circumstance, except for somebody who has an acute cancer, and then we got to have some precautions about how we do it. Okay? I'd have to look at how about the fusions and see what kind of state that they're in to give you a better idea of whether or not I think that's viable or not. It all kind of depends on how far along that is and whether or not I feel like that we're able to overcome it with regenerative medicine. But I've been, that's just like avascular necrosis. When you have avascular necrosis, you don't have blood supply to an area, and the hip joint's disintegrated, the bone disintegrates because it's dying. And if we can get new blood vessels and the bone come back to life, I'm pretty optimistic about anything. So anytime that there's a situation with a patient where either we haven't treated that particular condition, I have the resource from the Stem Cell Institute. We have over 100 clinics networked across the United States, so I can pull from that data resources. Have you had success with this? What was your success rate? What was, how many stem cells viability do we need as far as applications? I can get all of that data, and that's one of the great things about being an affiliate in a large network. Yes, ma'am.
My brother is a poor back surgery. He's pretty young. He's had a fusion and rods. You know that?
Well, here's the thing. Anytime somebody's had a surgery where you have hardware, it depends on what the mechanism of pain is. So let's take somebody who had a knee replacement or hip replacement and is still struggling. If we feel like that their mechanism of pain is coming from soft tissue, scar tissue, something in and around that area, absolutely. If there's a problem with the actual hardware mechanism, then the stem cells is not going to fix hardware that, like in other words, if the surgery was performed and we did some post-op imaging and they said, well, basically you got a screw putting pressure on a nerve, the stem cell's not going to take the screw off the nerve. I mean, we're going to have to do some kind of another operable surgery. If it's scar tissue,